Good evening to all the viewers. I am Dr. Shweta Ghadge from the medical team of USV. Recurrent urinary tract infection has become a common incidence among women and results in considerable morbidity and expense. Due to the repeat use of medications and increase in associated side effects, management of such cases have become difficult. Here to share with us his insights and clinical experience on managing recurrent UTI is Dr. Sanjay Gupta, sir, senior consultant physician and diabetologist with 35 years of clinical experience and is the director of SG Diabetes Center at Kamla Nagar, Delhi, which specializes in advanced care for patients of diabetes, hypertension, hormonal and metabolic diseases. He has been a teacher of undergraduate and postgraduate medical students and mentor in various physician training programs in diabetes care. He is a principal investigator in many international clinical trials and has publications in national and international journals. Welcome you, sir, and thank you so much for joining us today.
Good evening.
Uh,
Good evening.
so, sir, here to begin the discussion, I would like to know from you what is recurrent urinary tract infection and is there an increase in incidence of recurrent UTI, especially in summer seasons? And if yes, so, sir, what are the reasons for it?
Okay, so first of all, we must understand exactly what is UTI because I think it's one of the most common disorders that we see in our day-to-day practice. And I still personally feel that very often it is something which is not being treated properly. We have to differentiate between two basic classes. Uh, the large majority of people who have UTI is so-called cystitis, that means inflammation of the bladder. You can call it as a lower UTI or uncomplicated UTI. Any of the terms you can apply. For all practical purposes, that means that the patients have symptoms which are localized only to the urinary bladder. So, what are the common symptoms that the patient will come with? Probably increased frequency of urination, dysuria, suprapubic pain, urgency. But they do not have symptoms of fever. They do not have symptoms of chills, rigors, malaise, lumbar pain. Those are the symptoms which mean that the infection has gone up to the upper tract, to the kidneys. And then you can call them as either complicated UTI, you can call it as a pyelonephritis based on whatever pathophysiological mechanisms we are using. So this is point number one. One should understand that whenever we take history from the patients and we use the diagnosis of UTI, one has to clarify and specify what are you seeing. Are you seeing a simple cystitis, which is the most common disorder, or you see something which is called upper UTI pyelonephritis, and which has these are the two ways of differentiating what you are going to see in your practice. Number two, one should understand for a large majority, UTI is largely seen in women. It's a pretty common disorder in women, and male UTI is something which is uncommon. So for all practical purposes, there's nothing like uncomplicated UTI in males. Males seems to whenever you feel you have a patient who is a male and has urinary symptoms like this, what I'm saying, then you consider this as a complicated UTI. Don't Uncomplicated UTI is the term we apply only to the women subgroup. Okay, so look at what patient you are treating is a male or female, and then look at what are the symptom complex that you are seeing. So that is how you differentiate initially, number one. And right in the beginning, you highlight this. Then obviously, as you asked, in summers we do see much more higher incidence. And I'm practicing in Delhi. We have scorching heat here, and the dehydration that comes with this, the fact that people are not able to take enough water. A lot of people who are diabetics also tend to have haywire value hydration systems in this. Sometimes the drugs that you are using also cause maybe diuresis or dehydration. So you definitely become much more prone to, and then end of the day, sweating, local hygiene problems that can happen with the with the heat. So you do see a much higher incidence of UTIs in summers.
Okay, so here, sir, just to quickly highlight that there are two types of UTIs, that is cystitis and pyelonephritis, and that the incidence is very common in women. So it is very important for women to recognize the symptoms and take the immediate treatment that is necessary. So, sir, what exactly is the pathophysiology behind recurrent UTI or urinary tract infection first?
So let me first clarify the terms. What basically means recurrent UTI.
Hmm.
So again, as I write in the beginning, I specified that you have to differentiate. what type of UTI you are handling. Whenever we have somebody who has something which is UTI, which comes as and within span of 2 to 4 weeks, the same organism is re-isolated. For example, if I find a patient having E. coli infection, which is the most common cultures all my doctor friends will be seeing, then after 2 weeks, the patient comes back with another symptomatic episode, another something which is there in his hand with the same E. coli there, EPC. So then this is called relapse. So relapse is when you have the same pathogen isolated from the urinary tract and within a span of 2 to 4 weeks. Okay. Now, when you use the term recurrent means either the pathogen is different. So, for to clarify, if somebody comes with you with a urine culture which is E. coli today, and after 3 weeks the lady comes with another urine culture which is Klebsiella, so this is recurrence. This is no longer a relapse, whether even if it is coming within a span of 2 weeks or 3 weeks. Okay. Now, recurrence means to have either infection having twice in 6 months or three times within a year. Okay, whether the same pathogen or different pathogen, then we will call it as a recurrence. So this is what how you specify what is a recurrence. Third way is persistent. For example, you treated somebody, after 7 days you found another, the infection is not clearing, the urine is still turbid, there is still pus cells, culture is still positive. That is, the infection was never treated. So that is called persistent. So you differentiate between what is a persistent UTI, what is a relapse, and what is a recurrence. Okay. Now, whenever you see recurrence, which is the in actually speaking, almost 25 20 to 30% of women will have recurrent UTIs. Okay, recurrent infection. So recurrence rate is pretty high in women. If you look at the episode of UTI in a lifetime, almost 50% women will have some episodes of UTI, and 20 to 30% is a pretty high recurrence rate. So obviously, there are a group of patients who are not having recurrence, and there is a group of patients who are having recurrence. So there have to be some ways why this recurrence is happening. Now we have to understand one way of mechanism. Let's classify them as three ways: host factors, pathogen factors. Okay, so we look at whatever is the environmental or the other factors which are coming. So, for example, the host factors may be something which is wrong in the urinary tract. Patient may be having incontinence. Patient may be having obstruction, stroke, a calculus disease, a bladder outlet, obstructive ways, or patient can have genitourinary problems from cystocele, or prolapsed uterus, things which predispose the person to have some varieties of infection. The other way, maybe patient has metabolic diseases. For example, patient is a diabetic or immunosuppressed because of other reasons, gross obesity. All these things will again make the lady prone for recurrence. Then there are factors which are pathogen related factors. So the pathogen itself, the most important pathogen that we have is the uropathogenic E. coli, UPEC. Okay, so this is a pathogen which behaves in a different way in different people. And sometimes the bacilli that you are seeing have specific structural things. For example, they may be expressing the PTX3, and the PTX3 is basically a neutrophilic expression protection factor which may be deficient in the host. So if that is not there, the bacteria may persist, may or relapse, or the bacteria itself have a uroglactin 3A pathway, which what happens is that pathway is the one which allows the bacteria to go inside the endothelial cells or epithelial cells and stay inside longer. So there are factors which are related to the bacteria itself. The pathogen is more aggressive. The pathogens has factors which are making it stay longer. And then when I said environmental, there may be factors which are related to location. For example, we are talking about the heat of Delhi, or for example, patient has a poor hygiene, so she's not maintaining that hygiene well. And there are other factors which are socio-pathological. So there are factors which may be making the patient prone to getting a recurrence of UTI. So we have to look at all these factors whenever we are facing with the recurrent UTI complaints.
So, sir, here it is really important. You correctly said that, firstly, diagnosing and understanding the kind of UTI there is, whether it is a relapsed or a relapse UTI, or is it a relapse episode, or it is a recurrent episode, or it is a pathogenic, and there are multiple factors that can affect that per patient can be susceptible to, multiple factors that need to be considered while diagnosing recurrent UTI. So that was wonderfully explained by you. So, sir, here you mentioned about pathogens and the specific proteins that create issues and that lead to recurrent UTI. So sir, here can you also mention about if there is a correlation between gut microbiota and urinary tract infection?
Yes, so it is a very important question that you have asked. See, very often we think that the whole issue of urinary tract infection is localized to the urinary tract. So we do advanced investigation, including uroflowmetry, or we do ultrasound of the abdomen, looking at obstruction or any calculus disease. And we are practicing. I'm practicing in Delhi for more than 35 years now. We are in the stone belt of the country, so we see lots and lots of people with calculus disease who have stone as a predisposing factor for UTIs, very commonly. So we do ultrasound, but we tend to neglect the gut part. We tend to think that that is a separate anatomical pathway in our mind, so it should not be something which is related to UTI. Now let us understand that the flora and fauna, the microbiota that is happening, the microbiome is actually shared by in women. It is shared by the vagina and the urinary tract and the gut. So if you look at the species spectrum, practically the vagina has a species spectrum which is 450 odd, while the urinary tract has something like 550, 560 of varieties of microbiota, and the gut has a much higher, almost 1500 different species. But all these three species are overlapping with each other. We should also understand that lot of this colonization, the pathway, actually, if you look at the pathogenic pathway, imagine and the fact that the women are the ones who have so much of UTI is because of the anatomical issues. The anatomical issues is that there is a possibility of the gut flora to contaminate towards the urethral and vaginal side. So that's why you have this sharing of some degree of microbiota from the vagina, and then a similar a spectrum of, and in fact there are certain group of pathogens or certain group of microbiota which is common to all three. So if you have a gut flora which is disturbed, obviously you assume that the vaginal flora and the urinary flora will also get disturbed. Number one. Number two, the enteropathogenic or the uricopathogenic E. coli. What they normally do is the pathway they follow is first they go towards the vagina, then they colonize the lower urethra. They stay there. They form a bacterial film sort of thing, which protects them from the flow, which protects them from the local immunity measures that the human body has. And then this protective film let them push, and they let them keep them in the same area. And from there they can grow up to the bladder, and then they grow up. So that is the pathway, the locally extending pathway that the uricopathogenic, the commonest pathogen that we have, UPEC, that follows. And obviously the disturbance of flora makes it more prone. So that is why there is definitely a role of, right in the pathogenic pathway, the important role that is played by the gut flora also.
So, sir, here very very important point that is shared by Dr. Sanjay Gupta sir here is that there is a link between the gut microbiota and the vaginal and the urethral microbiota, and also that the dysbiosis in gut leads to a lot of infections and overgrowth of bacteria in the urethra and vagina. So that was again a very important pointer shared by you. So really thank you for sharing this highlighting pointer here. So sir, you mentioned about many risk factors, and especially women being more prone to because of the close proximity of the urethra and the vagina, and so there is a possible it's more susceptibility in women. So sir, is there also is this susceptibility to recurrent urinary tract infection inherited? Is it possible that it can be inherited?
Yeah, definitely. See, I think all of us who are practicing for long periods of time, we have time and again noticed that if the mother has a UTI, the daughter also comes to you. Number of times, the two sisters, siblings also both share the same UTI pattern. I think it's a very common observation. Now, this has been verified time and again that there are certain genetic factors and genoto-familial factors also, which mediate through various pathways. One of the pathways I pointed out is the PTX3 pathway, where the neutrophil itself lacks the capacity to prevent the recurrent infections. And then there are lots of locally expressive pathways. So there is a genetic susceptibility, and you will very often find a history of UTI, especially recurrent variety of UTI. I'm not talking about the first episode of UTI, but recurrent episode of UTI in the mother of the concerned patient also.
Okay, so there is a genetic possibility as well. So, sir, you mentioned about Delhi now being in a very scorching heat is what the temperature is there right now. So, sir, in your clinical practice, what are the common problems that patients come up with in terms of UTI?
So again, let's look at the symptomatic things and how people tend to misinterpret the, when the patient comes to us and he says, "Sir, there is some burning in urine." So that very often what we think is this is UTI. That's it. So the standard practice is just write a urine routine, urine culture, start one of the antibiotics, nitrofuran 10, patient goes off. Now we have to again look at the patient very carefully. Sometimes the patient is actually having no UTI, but the symptoms are because of UTI. Now let me elucidate some of these patients. For example, elderly women who very often have these atrophic varieties of vaginitis. They will have, local issues. They will have local burning. Sometimes they have local candidiasis, and they will explain that they come to you and say that this is burning. So we think that this is UTI, and then start treating it as a UTI. So one has to remember that there are instances, and for example, lots of these obstructive uropathies that I'm talking to, they involve a lot of stone diseases. So these are the patients who may have symptoms, but they will not have actual UTI. Obviously, the best way to differentiate is once you start do a urine examination, whether a routine or a follow-up with a routine in culture, you will be able to differentiate that this is having pyuria. Once you demonstrate pyuria, definitely you know that this is UTI. Similar problem with males also. Males very often have symptoms which are actually not UTI symptoms. They have prostatitis, so they have prostatic symptoms and they have difficulty in passing on. They have prostatic enlargement in elderly males, and actually that dysuria comes because of that. Similarly, in some women, they have incontinence actually, and this is stress incontinence that is related to basically genitourinary issues and no infective mechanism, but still have symptoms which are similar. So, number one, differentiate whether the patient has clear symptoms of UTI. And then I pointed out right in the beginning, always differentiate whether this is lower versus upper UTI before really
Yes.
diagnosing. And then step three, go ahead and diagnose by either clinical examination followed by urine examination.
So here it is very important, firstly, to diagnose, and secondly, the investigations have to be correctly, done so that the causative organism can be identified and the treatment can be started accordingly. So that's another very important point to be considered. So, sir, when exactly in a recurrent UTI or in a UTI, a further clinical evaluation is recommended?
Okay. See, what happens is if you look at the guidelines which are issued by the Western, this way, the guidelines say, frankly speaking, if you have differentiated clinically cystitis, you found the symptoms that I told you, dysuria or increased frequency, and no fever, no flank pains, no chills, then it is sometimes you actually don't need to do a culture, frankly speaking. So you do a urine routine examination. Obviously, you have to do always. You identify that this has and then there are various tests I will list it out. But in case you have a setting where there is possibility that there will be a drug resistant bacteria, and what are those settings? For example, patient already had previously a culture which was showing a drug resistant bacteria. Patient has a repeat episode of UTI, but previous culture report that she is bringing to you already has a bacteria which was resistant to A, B, C, D, E, F. Or patient has history of hospitalization, catheterization, intervention in any format, post gynecological procedures. Or lastly, if patient is living in a country which has prevalence of drug resistance, unfortunately, India is listed right at the top. If you look at the guidelines, India is right at the top, followed by the other Israel and then other countries. But we are right at the top of because of the rampant use of misuse. I will use the word misuse of antibiotics in our country. Fact that we are one of the first countries in the world to have fluoroquinolone resistance prevalence. So we are actually in that country list where cultures have become mandatory. So otherwise, let me again clarify. In case I was in UK, then I would have, and I find a cystitis. the nice guidelines does not tell me to go ahead and do a culture. They allow me to treat a cystitis just on the basis of a urine routine examination, because they assume that we will not have a drug resistant bacteria unless the other things that I listed. But in India, if I look at this fourth corollary, that in case you are living in a country or practicing in a country where drug resistant bacteria, then that means that mandates all of our patients to have, even if they are cystitis, to have a urine culture. Once you come into the domain of recurrent infection, that means you treated somebody, 3 months down the line she comes back with another attack, 3 months down the line she comes with another attack. Now you definitely need to investigate. So there are two separate things. One is the first episode of UTI, which I will again outline the treatment. But now, if the patient has come back to you again and again, then patient needs evaluation of the urinary tract, a gynecological examination in case she has a gynecological problem, an ultrasound to look at the any obstructive disease. You may need to adapt to do a uroflowmetry in some patients, and sometimes, in fact, an NCCT for stone disease or MRI may or may not be required. So, advanced investigations will be required to exclude, and then obviously a metabolic profile. You must know that patient is diabetic, a patient has hypothyroid, obesity, and other things. So we have to look at as I elucidated the patient factors, look at all the patient factors. In recurrent conditions, always look at all the other things. And you have to investigate step by step in these patients.
Yes, yes, sir. So you mentioned about antibiotic resistance being very it is irrational and inappropriate use of antibiotics, and also about the drugs in general that is taking place in India right now. So, sir, since you mentioned about drug resistance and about the treatment that is possible, so sir, what are the treatment? What is the treatment regimen for a recurrent UTI?
Okay, so I think I would I will talk about the treatment regimen right from beginning. So right from beginning means in case you have a cystitis, okay, which I just told you how to identify. Once we have a cystitis, you do a urine routine examination, do a urine culture, send a culture because of look at the drug resistance. But then you can straight away don't wait for the culture report. You can start treatment. Now the best treatment for which we can presumably start even before we see the culture is two drugs, nitrofurantoin or fosfomycin. Okay, so you standard practice is to use nitrofurantoin 100 milligram twice a day for 5 days, up to 7 days, or a stat single dose of 3 grams of fosfomycin. Okay, these are two standard, drugs that you issue. One should remember the importance of these two drugs. These two drugs do not have enough therapeutic potential to treat upper UTI. These two drugs do not really concentrate into the kidneys. So I very often see prescriptions, patient has a UTI without differentiating whether this is lower, whether this is upper, whether this is recurrent, writing, nitrofurantoin straight away, even if the patient is having flank pains. And this is pyelonephritis. So remember, fosfomycin and nitrofurantoin are drugs which concentrate themselves into the bladder. They treat very well the cystatic symptoms, but they are not good drugs for upper UTI. So we are not going to use them there. So these are the stat doses that you use. And once the culture report comes back, then you can look at that and modify in case you find the resistance is available, so, or present in any of this. Once you have recurrence coming in, now when we look at recurrence, first thing and foremost is evaluate why is the recurrence happening, and we just listed out all the factors, right from the host factors or the obstructive factors and other things. Uh, then we treat with various antibiotics. Now, the antibiotics that you can use for recurrence of UTI, the one of the most important drugs are again remain to be nitrofurantoin and fosfomycin. You can use them in case for cystitis. We are using them in a smaller dose, so you can use them in either 50 milligram to 100 milligram once a day of nitrofurantoin for 4 to 6 weeks, or you can use even weekly fosfomycin for at least a period of 6 weeks. So this is how you can treat this UTI in a recurrent way. But if patient has metabolic problems, diabetes, for example, needs to be controlled very well.
Uh,
Okay.
am I audible?
Yeah, yeah. Now you are audible.
So there was
You're
some
not.
network issue, so my net got disconnected. I'm so sorry. I'm so sorry. Sir, can you
Okay.
please continue with the
So,
treatment regimen?
so we talked about the use of antibiotics for recurrence. Then I told about the metabolic factors that one has to look at. The good old drug of sulfamethoxazole, trimethoprim, and even trimethoprim alone can also be used for for preventing recurrences. In case any of these drugs are not to be used, then for acute care, there are number of other, more often than not, we rely on cephalosporins or amoxicillin clavulanic combinations, but they are only to be used in acute care whenever we have, we are not able to use nitrofurantoin or the cultures. Whenever the cultures show you different antibiotic, you can rely on that. But more often than not, we rely mostly on antibiotics for prevention of recurrence. As I said, it is very important to look at the personal factors, the hygiene factors, the nutritional factors, the obstructive disease if it is present, because unless you treat that, patient will not go out of recurrence. Probiotics and the look at the flora modification can play a very good role in prevention of recurrent UTIs. We initially pointed out that number of the actual pathogenic process also has a colonization factor coming in. So in case that is happening, what we can always try to modify this. And if you use probiotics, which especially which will restore the flora back to normal, not only predominance of lactobacilli, but we have bifidobacterium, or if you get streptococcus faecalis. All of those are very important. If we use a multi-strain flora restoring probiotics, and we can restore the probiotic balance, then also the recurrence rates comes down dramatically. So I think it's an important thing apart from the over reliance on low dose antibiotics, because we are seeing so much of resistance to these drugs. I think the other factors play a very very important role, and we should not overlook the other things for prevention of or treatment of recurrent UTIs.
So that was wonderfully explained. And sir, here you have mentioned about limiting the use of antibiotics because of the very rapid and rampant increase in antibiotic resistance. So, sir, what are the alternative? You mentioned about probiotics as well. So, what are the alternative treatment strategies to limit the antibiotic use?
See, as you very rightly mentioned, there is a big problem of, and I think all of us who are practicing are seeing every day now urine cultures which are saying resistant to ofloxacin, resistant to ciprofloxacin. These are drugs which are so good still in the Western civilization. If you go to Europe and US, they are still drugs. The bacteria are quite sensitive. But here we are practically losing out. I don't think any even the enteric fever you can't treat with a single drug, ciprofloxacin or ofloxacin now. So these drugs are now gone out of our armory. We have to rely on higher grade of drugs, and very often than not, patient will go and get some sort of injectables coming in, because we are not able to control the infections by a good old ciprofloxacin. Now that brings into importance the other and very often when you see recurrence factors, very often people will come, the ladies come with no fever, 4 days of frequency, hurrying up, then they are okay, then after 3 days again having. So how many times can you get a urine routine and culture done? So you have to look at the other factors to restore this. Probiotics will be something which will probably give you long term relief, because it is not something which is going to alter in a day or two. Once you use that for a few weeks, the culture will get restored. Patient will definitely have lesser attacks of recurrent UTIs. But then some people try other measures. Like I see a lot of patients taking cranberries, a lot of patients using alkalizers. Frankly speaking, if you look at the research data, let's talk about the alkalizers. They are more often than not, they are just providing relief of some burning. They do not modify either the course of event, they do not modify the recurrence. Okay. We already know that, for example, if somebody gets a proteus infection in urine, the urine automatically becomes alkaline. So putting more alkalinity will not help. So alkalinity only helps in reducing little bit of burning because of the acidic urine passing through the urethra, but does not change the course of events. Similarly, cranberry, we do not find very any gross literature in favor of, or any studies which say, using cranberry will take away the chronicity of infection. But probiotics do have number of studies in their favor, and that can form a very important, part of our treatment regimen for this. Adequate hydration, maintenance of good hygiene, repeated cultures in case the fever comes in, or treating the upper UTI and obstructive disease will obviously have their own role in preventing recurrences.
Yes, so sir, again, wonderfully explained the multiple, not just treatment in terms of medications, but also, in terms of maintaining the hydration levels and maintaining a good diet is equally important. And sir, I thank you for, highlighting these pointers as well. So, sir, you mentioned about, recurrent UTI not being treated properly, and then patients coming back again and again with the same symptoms, and we cannot give keep changing antibiotics, or keep changing medications all the time. So sir, to prevent this situation, can probiotics be given as a prophylaxis in recurrent UTI?
So they obviously have a very good prophylactic role, because, as I said, if you're using a probiotic, you are not using it to relieve the urinary symptom. You are probably trying to use it to change the pathogenic pathway. You are trying to restore the flora. You are hoping that this, and also we have you have seen, and you must have seen the role of probiotics in chronic diarrheas also. What happens is they go and they replace the enteropathogenic E. coli by a normal flora. The similar thing happens in the urinary tract also. They will be going and occupying the the urinary specific, UPECs, and they will restore the flora. So you hope that the infection which is recurrent and which is lying there will get be overwhelmed by the normal bacteria. So it has a prophylactic role only. You don't give it for 2 days or 3 days. You give it for a couple of weeks. You see the response, and you can even extend. So most importantly, they are side effect free. So you do not have the problem of giving them and then you see what sort of side effects come in. And I think what I have found in my clinical practice is between 2 to 4 weeks, there is a good response that you can see with these drugs as a prophylactic.
Okay. So yes, so probiotics can be given as prophylaxis, and it not just treats the symptom. It does not just provide a symptomatic relief, but it tries to replenish the already the bad bacteria, as the EUPACs, and tries to replace it with the good bacteria. So again, a very good pointer highlighted by sir here. So sir, here I would also like to ask you now, since probiotics also there are multiple formulations that are available. So what is the benefit of multi-strain probiotics in recurrent UTI?
Again, see, when I said the biome that happens in the urinary tract and vagina is a very large biome, almost 450 odd species. But if you look at those 450 odd species, the dominant species are only 5 to 6. So they occupy the large chunk of the biome, and the smaller parts of are with the entire other variety and the species of bacteria. So lactobacillus being the one of the most important central core, and it's something which is very sensitive organism and dies very fast. But then there are other very important bifidobacterium, streptococcus faecalis is a very important component. So if you try to replace only one variety of probiotic, then probably success rate is likely to be less, because that is not the only species which is prevalent. So whenever you use the most important thing is to use any product which at least restores 3 to 4 major components. There is no idea of you replacing only one, because it's not going to be one particular species which is not prevalent. The deficiency level is pretty high. So what we need to do is at least 3 to 4 major core things must be replaced. So that is the reason we are going to be benefited only when we are using multi strains rather than using only one single strain of lactobacilli. Lactobacilli has to be a component, but then other, including the, as I said, other 3 4 major components, including streptococcus and bifidobacterium, they should also be a part of the restoration of flora.
Great. So, sir, so you I mean to say that there is a synergistic, effect of the strains of the probiotics, which give an added benefit, and they replace the bad bacteria and create a very healthy flora in the genitourinary tract. So again, a great pointer highlighted by sir here. So, sir, one more question that I would like to ask you is: can probiotics be given in pregnant women with recurrent UTIs?
Okay. See, pregnancy with UTI is again a almost a chapter of its own, but it's something very important. We know that the asymptomatic bacteriuria that happens, and in India, almost 25 to 50% of ladies in pregnancy have asymptomatic bacteriuria. Now, previously, people used to think that it probably is not that important because there's no symptoms. But we know that it has been related to number of coexisting maternal complications, including preterms and lots of other complications. So, number one point to be taken home is that don't you just dismiss asymptomatic bacteriuria in pregnant women. It needs to be properly thought of and investigated. Now, the trouble is that the antibiotics that we want to use in pregnancy are very limited. Okay, we don't have a liberty of using the standard core drugs. That phosphomycin is safe in pregnancy. You can use nitrofurantoin. I would not give in the first trimester. I won't use in the last trimester. In the middle trimester, you can use. It is allowed to be used. Septran and the sulfamethoxazole trimethoprim combination, again, last part, third trimester you cannot use, first trimester you cannot use, second with caution you can use. So the classical three cystatic treating antibiotics are limited in use here. Then we have to rely on then cephalosporins, after which there are again limitations of use. And unless there is a gross need and patient has a complicated variety of UTI, then I will really resort to these other drugs. So in such setting, in case I have a harmless probiotic, either helping my first generation drug or helping on its own to prevent recurrence, so it's a good choice to make. We have, I think, enough studies to show that probiotics can be used in pregnancy without any complications of any variety. And as a general use, we always try to limit overuse of any drug in pregnancy. So I personally feel that a use of 1 week to 2 weeks of probiotics is reasonably sufficient unless patient has more relapses.
Okay, great, great. So there is, a lot of studies that, like you mentioned, about probiotics being safe to be used in pregnancy, and a 1 2 week course should, do the necessary step that needs to be taken for restoring the bacteria, the good bacteria in the genitourinary tract. So, sir, since there is so you are a diabetology practice that you do. So, sir, how is your experience with probiotics in diabetic patients having UTI or recurrent UTI?
So now, as a diabetologist, I have done a consultant physician practice for not more than 35 years, 38 years plus. So, UTI, treating UTI, I have started the domain of when, in fact, uh, fluoroquinolones, the first trials came to Maulana Azad Medical College way back in '84, and I was a part of that trial. And like, believe me, ciprofloxacin, when we use, my boss gave me the bottle of ciprofloxacin. He said this is a trial drug. I went to my ward. Any patient you give that drug, all infections cured. It looked like magic bullet. We were actually, all of the residents were hunting that somehow we can get hold of that tablet. If we get that tablet, patient will be okay. Because so much was the effect, because it was not there at all. The microbes were never exposed to such drug. Even if patient has huge abscesses, you give them, it disappears. But now this is so pathetic to see that the drugs are gone. In diabetes practice, this is a big problem. This is always a big problem of poor immunity. Now additional headache has come because of the SGLT2 inhibitors. So more and more of diabetics are on SGLT2 inhibitors. Now SGLT2 inhibitors,
Yes.
create a further domain of more genitotract infections, the GTIs and the UTIs. So we are now, again, I think focus of all diabetologists is to look at the UTIs more clearly and more carefully, because this additional drug, and they are now being used left, right, and center everywhere, not by diabetologists, by cardiologists, nephrologists, neurologists. Everybody is using them,
Yes.
and I think all general
Yes.
practitioner friends must be seeing patients who are on this. So I think UTI is back in focus, especially the fact of recurrent UTIs in this. uh, we do find that in case you are using not only, and this is my personal experience, not only UTIs, even GTIs come down. The the fungal infections also come down in case you restore the flora, because again they share all the Candida species tend to thrive on the background where there is poor microbiota domain. If the natural flora is there, it competes with Candida. It competes with all the fungi. It does not allow the fungi to stay on. So I think it is not only probably in future with it does need good research to see, but it's a general clinical experience of of all of us who are practicing diabetology and who are looking at the SGLT2 inhibitors, that it does help to use a probiotic not only in UTIs or recurrent UTIs but also in GTIs. It does help. So we can try using that.
So yes, sir. So another point highlighted by sir, that since he started using an antibiotic, first trial that was done by him, sir, is ciprofloxacin, right?
Yes, yes, it was
Yes. So
ciproflux.
ciprofloxacin is the drug that we started with, and now it's come to a point where it is very difficult to control a resistant case. And in that, probiotics and with the multiple drugs that are given to patients, especially with diabetes, chronic diseases like diabetes. So probiotics does help in restoring the flora and alleviating the symptoms of recurrent UTI. So I thank you so much, sir, for beautifully explaining each and every step, each and every pathogenesis and investigation, and the importance of each and every step towards treating a recurrent UTI. So, sir, lastly, I would like to ask you, what is your final message to all the viewers who have joined us today?
Okay. Uh, Two very important parts of today's thought. One is remember, l- differentiate the UTI. Look at what exactly is this. Is it a lower UTI? It is just a simple cystitis, or it is a complicated UTI or pyelonephritis. Two need to be differentiated and treated differentially. Identify very carefully what is the nature of illness and look at all the factors that we talked about. But I sincerely feel it is our as a composite a social duty of all the doctors to use antibiotics more judiciously. Do not use unnecessarily. Use antibiotics according to their possibilities of use. For example, I just told that for cystitis you don't need to use complicated. People are using carbapenems. People are using all variety of drugs. You don't need. Cystitis is very well controllable by simple drugs which can be given only for lower UTIs. Then please use antibiotics in their proper dosage. Don't give antibiotics only for 2 days or 3 days. We are not going to contribute. This is our this. If we do this sort of practice, we will be contributing to more antibiotic resistance, and more antibiotic resistance will come back and bite us again. So it is something which is a demon that we will create, and this demon will come back to us. So I think it's our all moral duty of all of us who are practicing medicine to be careful about the use of antibiotics. Use antibiotics judiciously for proper duration. Follow the guidelines. I think that will help us to treat and use these antibiotics for much longer duration. And I pointed out, look at the pathogenic factors, look at the way that we can prevent recurrent UTIs, not only by simple antibiotics, but all of the other factors, including probiotics, including good hygiene measures, including looking at the base causes, and we'll be able to treat these UTIs much better.
Great, great. So highlighting here, that there needs to be a very correct diagnosis, firstly, and secondly, the judicious use of antibiotics, and thirdly, focusing on, probiotics as a key here to, replenish not just underlying symptoms, but also taking care of the underlying cause here. So I thank you, sir. My sincere thanks to you for such a wonderful session wherein we touched upon each and every subject, and I'm really happy to be a part of this discussion with you, wherein it was a learning for not just me, but I'm 100% sure for all the viewers as well, who've got to understand the key insights in managing recurrent UTI. So thank you so much, sir, for your time, and I hope that we have more such discussions in the future. Thank you.
Thanks a lot. Thanks a lot, and thanks to all the viewers. Thank you.